So importance of psychiatry, 50% or more of patients referred for bariatric surgery are reported to have an axis 1 or 2 diagnosis. It's all axis 1 now. There's no axis 2 anymore in psychiatry. There's just one axis. But if you look across samples of different, the literature out there, it actually ranges anywhere from 20 to 60% of folks. And we actually have some information coming up on binge eating disorder with how many people with that diagnosis are more likely to have at least one other psychiatric diagnosis or 3 or more diagnoses. And the more diagnoses you get, you sort of add to the bandwidth, and it's going to put them at higher and higher risk if you're not able to give them appropriate education and counseling. Approximately half of folks coming in for evals are already on psychiatric medications. If you have a psych illness any time in your past or current, it does put you at an elevated risk for not losing as much weight or maybe not doing as well post-op. But there's ways to maneuver that and deal with that with folks. And, or losing the weight and then having the weight come back because you get off the train. And then binge eating behaviors are suspected in about 30% of folks preoperatively. And those are really important to identify because you're trying to identify things that are going to help people afterwards. It's probably not very comfortable to binge eat after you've had a bariatric surgery. So, and puts them at increased risk for complications. So some of the medications that can cause weight gain in psychiatry, and this is not picking on any specific medication, but it's just something that we might be looking at pre-morbidly, that if they're on something like this, we want to set them up to do the best possible when they get done after the surgery to have the best weight loss they can. And so it's important to know, before they started on psych meds, where was their weight, what's happened since they've been on them, have they had certain side effects such as weight gain, and just compliance in psychiatry with medications, weight gain, sexual issues, daytime sedation, flattening of cognition. Those are huge reasons why people become non-compliant with their medications and their treatment. The literature shows in psychiatry that if you start on an antidepressant or a antipsychotic, you get about a 50% fill rate to go to the second prescription. So hitting them to not have side effects just increases that greatly. And also to talk to them about, if you're going to have issues, make sure you're calling us so we can change it, or we might, if they have those things, that's when we do things like the pharmacogenetic testing to look at that. The tetracyclics, mirtazapine could be a weight gainer, paroxetine's a definite gainer. And there's just different ones of them. Things like amitriptyline that's used a lot for headaches. As that dose goes up, that can be a weight gainer. The antipsychotics, the second generation antipsychotics, can cause some significant weight. Clozaril, which isn't used as much by folks, is the number one. Zyprexa, olanzapine's a big weight gainer. Seroquel and resveratrol are down a little bit further. Then you get to Abilify and Geodon and Latuda as we go down the list there. But those are all, and when you put them all together, all these things add up. And some of the mood stabilizers can add to that. And this got put on there, the Zolpidem, the Ambien, and I go, what? It doesn't cause weight, but it does in a certain segment of people because they get up and they eat and they don't realize that they eat, and then they have the food around the house that they didn't know was there in the kitchen. So it's just sort of taking all those things into consideration when evaluating and treating folks. And this is really no different than we do in our regular evals with patients, because this is what increases adherence to meds anyway, if you're able to go through folks about this. This is probably already talked about, so I'm not going to talk about it, but we just put in medications that are out there to promote weight loss. I know we work with some of these in our own practice. Some of them work better than others, and there's a lot of individual variability to that. But there are a lot of things that can help folks out pre-morbidly. So.
The first one, Wellbutrin, or?
Yes, Wellbutrin and naltrexone. So, So before that medicine was out, we were using Wellbutrin and naltrexone together. We've used Topamax by itself quite a bit. And you can see Topamax, which is topiramate, with phentermine, which is a stimulant. So there's different meds are out there, and some of them work pretty well for folks, and some of them don't work very well. When you do certain ones, such as lorcaserin Belviq, that works on serotonin. So if you have other serotonin agents on board, whether it's an antipsychotic that works on serotonin or SSRI or those, you have to let people know that you're at risk for serotonin-like side effects, syndrome side effects or things. And so far that hasn't been an issue, but it is something you need to let people know about. This is a slide you have to memorize. So when we do a psychiatric assessment and they come to us for a psychiatric assessment for bariatric surgery, we do a regular assessment looking at their history of present illness, their past psychiatric history, and the meds they've been on, the side effects, family history, because we want to know about things like diabetes and heart disease and other types of illnesses, bipolar, suicide, things like that in the family tree. Substance abuse, of course, is going to be very huge, and current substance abuse versus past substance abuse. Are they a binge drinker? What type of help do we need to get them in that area? We do our mental status, but then I think the next slide sort of shows we do some special, well, it's probably going to be down here. We put some of these together this morning, I'm sorry, so they're probably out of order, but we also do some special things just for the bariatric eval, and they'll show up a little bit later. So we look at the past and present mental capacity. Of course, somebody has to be able to give informed consent. And do they have realistic expectations for the surgery? I mean, that is huge. And, so, you don't say, well, are you going to be able to do X, Y, Z? You say, what do you expect from the surgery? What do you expect to be the outcome? What do you think is going to happen over the next 3 months afterwards, 6 months? And see if somebody can really give you a coherent picture of what their expectations are. If they're realistic, if they're not, do they understand it? And if they don't, make sure that we get that type of information for them. A description of their affect, their mood, what we see. Somebody wants the surgery really, really bad. And I say, oh, I'm happy, everything in life is great, but they've just told you about their life is sort of not going too well, and they're sitting there crying, and there's probably a little bit more in depth you need to go to. Because people, by the time they get to this point, they've probably been through a lot of episodes of trying to lose weight, and they really are really hoping that they can do that. Or they might just be crying because they're just finally so happy to be able to be at this point that there's going to be something that really might change their life. And that's a whole different thing. So that's a very positive crying episode you have. So describing the source of stress in their life, and maybe something they might need to be in some therapy. So we're addressing, they might have just gone through a divorce or a job, something that's stressful in their life, so that's going to put them at risk not to do quite as well post-operatively. So we want to make sure we take care of that. And we talked about the drug use and any history of drug use. We also do tox screening, urine drug screening, and it's a little amazing how many people will say they don't use anything and they just happen to use something, but, well, Or I had the guy come in yesterday, this is a true story, I had the guy come in the other week, and I thought he was having problems because of alcohol. So I asked him how much he had to drink, and he says, oh, I have about 6 a day. And his wife just stared at him. And she said, that is not true. You drink at least, a 12-pack a night. And he says, well, I know, but you go to the doc's office, they tell you they're going to double everything you say. So I drink a six-pack a night. So that gets into the thing, if you do something like urine tox screening, it's not only that is it positive or not, but what is the, how high is it? So some of the urine tox screening looks at just whether it's positive, negative, like they do point of care, you get an immediate result. But there's also confirmation testing that can look at the exact amount that's in your urine. So that's sort of important when you're getting down to that type of working with somebody who has that history and you're trying to get them out of an addiction.